sleep medicine for about 30 years. And I like to thank my lucky stars that I got into this field many years or many decades ago. And then I enjoy every bit of this. I enjoy clinical sleep medicine. There's a lot of satisfaction when you treat these our patients suffering from sleep conditions, especially sleep apnea. We do research in sleep medicine, and certainly this has been highlight of my life and my career that I participate in sleep medicine. I hope some of you are already practicing sleep dentistry. If not, I will encourage you to be participating in sleep dentistry. It is very satisfying field of medicine or dentistry for that matter. And I'm sure you will enjoy it. You'll enjoy the interaction. You'll enjoy treating your patients and the satisfaction you get from a very state-of-the-art treatment that you can provide to your patients, and how much health improvement you can lead to your patients, how much benefit you can provide to your patients. So it's it's amazing. So my task today will be to do a brief overview of what sleep apnea is, pathophysiology of sleep apnea. I will go over some treatment options, briefly touch upon CPAP, and then my colleague, Dr. Jamali, who is the expert dentist we have, sleep dentist we work with, so he will take over rest of the talk. So what is sleep apnea? So sleep apnea is, in very simple definition, it is a disorder which occurs when we sleep. There is recurrent episodes of narrowing or collapse of your airway, your pharyngeal airway during sleep, while person makes an attempt to breathe. So person tries to breathe, but you cannot breathe because your upper airway is closed. So you could see these diagrams. The top one here is a normal breathing. So I know all of you can appreciate the upper airway anatomy here. We have the nasal airway. We have an oral airway. You have the tongue here, and this is the pharynx. So this is a small portion of our airway, which is prone to collapse during sleep. That's amazing why anatomically or physiologically we were designed to have this type of airway. There's no cartilage here, there's no bone here. This part of the airway is fully controlled by the muscles and the soft tissue. So it is very prone to close when we sleep. It does not close while you're awake, only occurs when you sleep. And you can see the bottom diagram here where the airway is closed, the tongue moves back, soft palate is occluding the airway, and person is not able to breathe. So this is what we call sleep apnea. So what happens when you cannot breathe? One, you cannot take oxygen or air to the lungs. The air does not move to the lungs, and your oxygen level drops, which is not nice to have. And second, what happens when you cannot breathe and you're sleeping? You physiologically, we are designed in such a way that you will have an arousal. You will attempt to breathe. So the sleep gets fragmented. Person wakes up briefly, is a physiologic arousal, and the sleep is disturbed or fragmented or interrupted, and then we start to breathe again. So the two primary events that occur. One is oxygen drop and second, sleep interruption. And we get a lot of health issues related to low oxygen and repeated arousals from sleep. So just to keep this definition in mind, because you will be hearing about these over and over again today and later on in your careers. So apnea, hypopnea, they primarily mean the same event. So these are sleep events. Apnea we define as complete cessation of airflow. So almost negligible or no airflow occurs during apnea. Hypopnea we define as the airflow occurs but decreases to about 50%. And both of these events have to occur for 10 seconds for us to count them as apnea or hypopnea. They mean the same thing. The oxygen will still drop, and there will still be arousal from sleep. Apnea-hypopnea index, AHI, is total number of apneas and hypopneas per hour of sleep. So that's a number we always keep in mind. There have been other terms that have come into the literature, oxygen desaturation index and hypoxic burden, but primarily everyone follows apnea-hypopnea and apnea-hypopnea index. Interestingly, we all have certain apneas or hypopneas during our sleep. So all normal human beings, all of us, do stop breathing for a few times every hour. And that normal number to keep in mind is 0 to 5 events per hour. So up to 5 events per hour, we will call it within normal range. And over 5 events per hour, we will call it abnormal or sleep apnea. There is another type of sleep apnea called central sleep apnea, which is a rare condition. By far, when we speak of sleep apnea, it is really obstructive. It's very common, maybe less than 1%. We see it often in our practice, but very rarely you will encounter central sleep apnea. We primarily see it in people with heart issues or heart failure, and we see quite a bit of this in people who are using narcotics or so on, or other drugs. So when we talk about sleep apnea, what happens, as I alluded to, this is the area which causes all the problem, all the issue. So this part of the airway, you can see, we talked about that briefly, is all muscular and soft tissue. There's no cartilage. Further down in our airway, trachea has cartilage. This is all controlled by the musculature and soft tissue. So that there are two types of muscles that predominantly control your airway. We call them constrictor muscles and dilator muscles. So the pharyngeal constrictor muscles close the airway. The dilator muscles make the airway patent or keep the airway patent. And so it is kind of the balance between these two muscles that determines whether the airway is closed or open or remains patent. So it's very important to know where the problem is and what causes the problem. So physiologically, problem can occur predominantly in the nasopharyngeal or nasal airway, nasopharyngeal airway, velopharynx, which is further down here at the back part of the tongue, or near epiglottis. The problems can occur predominantly in different areas, tongue base, or lateral pharyngeal walls, but in the end result is that the airway is going to be narrowed or closed or collapsed completely. Again, pathophysiology, so this theme goes over and over. My apologies for repetition. This is the normal airway, as you can see, nasal airway, pharyngeal airway, and uvula soft palate, and so this is normal patent airway. This is hypopnea, which is partial occlusion of the airway. The airway narrows, not completely closed off, and with apnea, as you can see, there's complete closure or occlusion of the airway. Same idea here. I will skip that. So this is a video. I'd like you to pay attention to this, please. It is self-explanatory. So let's see. So you can see the air moving normally in this video. Everything is patent. The airway is patent. Again, supine position, patient is lying down or individual is lying down. So now there is occlusion. Tongue has moved back, soft palate is occluding the airway. This is sleep apnea. So person cannot breathe, so he's woken up, he's trying to cough or move or trying to open up his airway. Sleep now resumed. There was interruption in sleep initially. So yeah, so he's starting to breathe now. And the whole thing will be repeated over and over. So this is what we see when we do a sleep study. You have to do a test for these individuals. So briefly, I would like to point out what we are interested in seeing. So airflow means the airway, we measure it by a pressure transducer outside the nose. So this is airflow. Airflow means the person is breathing, air is coming in and out of your nostril. This is effort. So we measure thoracic movement and abdominal movement, the chest movement and abdominal movement. So these are the movements you can record, and we are recording the oxygen here. So as I previously pointed out, two things are happening. Person stops breathing, no airflow, apnea. It has to be for 10 seconds. However, the effort to breathe continues. The person is continuing to breathe, but the airway is occluded. And there is no air movement into the lungs, oxygen level drops. So here is over 90%. So this person is dropping it to 70 or even lower. So this keeps on repeating and repeating all night. Highest level of apneas I ever seen, I'm not sure that was correct, was 160 events per hour. That's very high. And we said 0 to 5 events per hour is the normal range. So average people we see are 20, 30 events per hour. Severe we see sometimes 60, 70 events per hour. So once every minute, person is stopping to breathe. So significance of OSA or sleep apnea, as we talked about, the air does not go into the lungs, oxygen level drops, 90% is the cutoff. So these people sometimes go fairly low, 80s or 70% of oxygen concentration, or there is arousals from sleep. So if you're waking up throughout the night, several minutes, several times every hour, many times every hour, you're not going to get a refreshing sleep. You're not going to get deep stages of sleep. Therefore, person will be unrefreshed upon waking up. They will be tired and sleepy. They're prone to get into the motor vehicle accidents. These could lead to life-threatening problems, and it's very common. It is one of the big risk factors for all cardiac diseases and the CNS diseases such as stroke and TIAs, heart attacks, coronary artery issues, hypertension. So it's a because your oxygen is dropping all night long, that makes you prone to get into atherosclerotic and other sort of problems. So it is a devastating health issue for many people. Okay. So what happens from sleep apnea? So this individual you can see here is tired and sleepy, sitting on a bench. He falls asleep. Um, this is extreme example. Most of our patients are not that severe. Most of our patients are mild to moderately sleepy. They can function, right? You can overcome sleepiness. You can get up, walk around, you can start doing something, you can start talking. People can overcome that, but you are still fighting to stay awake. So my question to the patient is, not that you're asleep or you're falling asleep. That's extreme example, but most of the times people will say that, oh yeah, I'm in the afternoons. I'm sort of trying, I'm not feeling the same. I'm struggling to stay alert. I'm struggling to focus. So some of that occurs. Impaired cognitive performance, that means there's good evidence that cumulatively, when there is so much injury to your brain and the rest of your body from low oxygen, hundreds of times every night, that sleep apnea is a risk factor for dementia and other cognitive disorders. And we always look out for it. People in early stages of dementia and so on, Alzheimer's and other conditions, we look for sleep apnea, and if we find, we try to treat it quite aggressively. Motor vehicle accidents, so very big problem. I'm sure in India, very big problem in North America. So generally, the saying now is that if you have sleep apnea and you're driving, you're worse than a person who is drunk and driving. So it is even higher risk than higher risk of getting into the accidents compared to drunk driving or drinking and driving. So very big problem. I think the literature the research has shown that people who have sleep apnea are 10 to 20 times the risk of falling asleep driving and getting into motor vehicle accident. So big issue. And cardiovascular issues we talked about. I think respiratory issue, they can develop pulmonary hypertension and right heart failure and so on. So, so what are the risk factors for sleep apnea? There are many risk factors. However, you may not have any risk factors. People can still have the problem. So, although we focus on obesity, obesity or being overweight, but this is not always the case. In fact, 30% of the patients we see are not obese. They may be overweight, but not obese, and a lot of those patients, like 10 to 15%, are normal weight or on the low side. So, but it is a risk factor. Age. So obstructive sleep apnea is more common as we age, and I think I have a slide about it. People over 50 or 60-year-old year of age are almost twice as much as likely to have sleep apnea compared to people who are in their 20s and 30s or 30s and 40s. So from 40 onwards, it's a as you say, everyone say, it's a downward slide. You develop all sort of conditions. Women are protected while they are young from sleep apnea. So younger women will have less prevalence of sleep apnea compared to postmenopausal women. So the sex difference is almost equal after the women are in menopause, after 45, 50 years of age. Okay, the smoking and alcohol consumption. So these are very, very important risk factors. Smoking nearly doubles your incidence of developing sleep apnea. So 2 times as much, and alcohol consumption likewise. So the smoking, we don't know all all the physiology and others why it makes you prone. Probably it causes more inflammation of the airway and affects the nerves and so on. But alcohol consumption we know very well. It's a big risk factor. It helps you gain weight. Not only that, the alcohol is a CNS depressant, and also affects the musculature of the upper airway. So it makes the constrictor muscles or dilator muscles weak, the pharyngeal dilator muscles weak, and people develop sleep apnea more commonly after alcohol consumption. So that's a big problem. So sometimes we do a sleep study and we find, I say, oh, mild sleep apnea. Why you're so symptomatic? So then you go with the history and so on, and then you say, oh, yeah, but the person is a habitual drinker or drinks, many beverages every evening. So, but we don't do a sleep study because they have to drive to our sleep center and get the study done. So, of course, people are not going to be drinking and driving for a sleep study. So we miss out on that. So myself, I adjust for that. So if somebody is mild and is a person who consumes alcohol regularly, so I would say those are just double it up or higher. So they are moderate or severe probably, and you should be treating those patients. So sometimes there are anatomical predisposing factors. These are not many, but you'll be able to see in your practices. People may have retrognathia, overbite or underbite, may have nasal issues like a nasal polyps or deviated nasal septum. So that all comes with Dr. Jamali will also talk about it, the physical examination of these patients. So one factor I always look for, one condition, that's large tonsils, especially in my younger patients. So sometimes they will present with, fairly big, large or grade 3 or grade 4 tonsils, and tonsillectomy can lead to a cure for these individuals. Okay, and just keep moving. So cardiovascular problems. So the reason I included that here, the sleep apnea not only causes cardiac issues or a risk factor for cardiac issues. However, people who have cardiac issues like heart failure, other heart issues, also are prone to develop sleep apnea. So it's like both ways, it's bidirectional. This thing, sorry, we talked about this age factor. So prevalence of sleep apnea in people who are 60 years or higher is about 25 to 30%. And in India, there's some numbers in India which are mind-boggling or staggering. So they're saying up to 40% of population may suffer from sleep apnea. So these are huge numbers. I think Dr. George talked about it. So we have, let's say, 8 billion people in this world. I think 1 billion people suffer from sleep disorder breathing or sleep apnea. That's a huge, huge number. And out of those, I believe 250 million will be in India. Even if you half that, there are a lot of younger people in India, I believe. So even like 100 to 150 million people in India are out there who are needing therapy, diagnosis, and therapy of some kind. I think we talked about it. I'll skip this. So again, just look at the big tonsils here. This is retrognathia. We don't find too many patients like that, but there's something to look for. Again, you're going to treat them with our current therapy, heart problems, alcohol, and sex difference we talked about. So yeah, this is a very good slide actually. It's hard to read. Some of the wording is small, but sleep apnea is such a condition that pretty much affects all your body. If you're going to have low oxygen, the rest of your body is going to get low oxygen, and every organ is going to suffer some kind of injury. It's not going to be acute, like injury over one night, but cumulatively over years and years and decades, people gonna suffer various injuries. So all kind of brain disorders, heart issues, high blood pressure, heart attacks, you name them, metabolic endocrine problem, and actually obstetric, very, very important. We are looking out for those. Certain percentage of women during pregnancy develop sleep apnea and various issues related to that, and we definitely treat them very aggressively. And the mortality, very well known that it is one of the risk factors for high mortality, lung conditions. So it affects all your body and everything, and concentration, memory, your production, like how productive people are, and so on. So it is a very serious disorder. So, it's a serious and dangerous disorder. We all know. We all need to pitch in to look for this condition as healthcare professionals, yourself, dentists, and ourselves, physicians, and other healthcare providers. We all have a responsibility to look out for these people, help them out, guide them into proper way to get a proper diagnosis and proper therapy. So the problem is so huge. It's, as I said, billion people in the world needing care, and no one profession can do it. In Canada, we're small. We have 40 million people only. And do you know how many sleep physicians are in Canada? I know every one of them. There are only 500 sleep medicine experts in Canada. How can 500 people look after, let's say 5 million patients out there? Impossible. So that's why we're encouraging our other partners in healthcare, other physicians groups, specialties, family physicians, or general practitioners, and a big health group out there is dentists, like dental practitioners. So almost everyone sees a dentist for dental issues. And I personally think dentists are in a best position to assess patients. They're out there looking at the airway, of course, dentition, but airway, everything. They can ask them various questions, and you don't have to ask many questions to screen for sleep apnea. Just 3 questions will suffice, and then they're also now in best position to treat most of our sleep apnea patients. So I think dentists or dental practitioners are the one who could make a big difference in this whole sleep apnea condition. So this is my slide here. So it's not just respiratory, ENT, dental. Everyone has a role to play. All you have to do is ask 3 simple questions. Ask about snoring. Ask whether they gasp or choke during sleep. May not be common, but worth asking. Or you can ask the bed partner. And other question to ask is, how do you feel when you wake up in the morning? We all should be waking up reasonably refreshed. And if person is not waking up refreshed, is still tired, not fully ready to go, ready to handle go out, handle the world, and if they're tired and sleepy during the day. So if you have two out of these three questions positive, I think these should go on to get the testing done. You can screen more formally by a stop bank questionnaire, which is a very simple questionnaire, and we should all have them in our offices, and we should really screen for sleep disorders. This is something we can talk about more later. There's a big responsibility to our patients from dentists and physicians that we should be looking out for this condition. I think specifics we'll talk a little later. Okay, so what do you do when person says, yes, they snore, they're not waking up rested or refreshed, and they're tired during the day. So you can take little more detailed history, which we do. And so for especially for dental professionals, TMJ evaluation, dentition evaluation, you can do a sleepiness scale. It's a simple scale which which patients do subjectively. There are 24 points you can score, which is the highest, and over 10 points. If you score over 10 points, that means they are sleepy. So it's more subjective, but it's a good measure that they're tired and sleepy. So I even say anyone over 7 or 8 is worth looking at, or that's significant. Stop bank questionnaire. We can send it, Dr. George will, and our dental care team can send out those questionnaires to all of you. You can print them and keep in your waiting rooms. People can just score themselves and bring it to you. So once you have a preliminary clinical diagnosis, then this is one condition where you need a testing. So I'll come to the test in a minute here. So some of these symptoms, I think we talked about it. I'm not going to talk more and more, but so snoring is a big issue, witnessed apnea, so not always there. So if a spouse or bed partner is saying the person has apnea, that is significant, choking and gasping through the night. And believe me, that a small percentage of patients come in as they cannot sleep. They cannot maintain their sleep. They cannot sleep through the night. So these don't pass them off as insomnia. They may have actually sleep apnea as underlying condition. So excessive sleepiness we talked about. I think some of this I'm going to go faster. Person is dozy in front of computer here. This is Epworth sleepiness scale. Again, a self-scoring, subjective scale. And this is the stop bank. We will send it out to you. So all simple questions you ask patient, or patient can self-score themselves. And if you have over 3 points here, those patients should be going for a diagnostic test. This is a physical examination, and I'm sure you're well aware of that. I think Dr. Jamali has a slide on that, so I will leave that. So then you need a test. This is one condition. You cannot confirm diagnosis based on history and physical examination. That's important, but you have to go for a test. So the test is a sleep study. A formal sleep study is called polysomnogram. That can be performed, but you do not need that. That's a detailed sleep study. We do them in the lab. There are like 16 channels we record. It is the best test. It's the gold standard, but it is not needed. Majority of the times, we only need a home test, which is fairly simple test. As you can see, we do them at home all the time, and this is sufficient in 95% of the patients. There could be simpler tests like a watch pad here, and there are other home design, like every country, every region has their own testing. Nothing wrong with those, so they're all good, but you have to do a test. So that's how we grade sleep apnea. 0 to 5 is normal, mild 5 to 15 events per hour, 15 to 30 events per hour moderate, and severe is 30 events per hour. So I'm going to actually go into the, So this is a home test. This is the data you get. Apnea hypopnea index here is 23 events per hour. Um, sorry, 18 events per hour, which is moderate, 15 to 30, between 15 to 30 events per hour. These patients can go on to get treatment either with oral appliance or CPAP. So this is the result we get. There's something about hypoxic burden. We are researching on that. I think that's a better parameter to look for follow-up at least, but that's something later we can talk. So I'm going to spend just a few minutes on treatment and then have Dr. Jamali take over. So there are not that many treatments, unfortunately, out there. there so there's no role for medications. Okay, so I just put it here, this in here to say that we do not have a medication to treat this condition. There's a small role for surgery, not a big role. um, Children, yes, there's a role for people under 18 or so, 16 year of age. If they have large tonsils or adenoids, we remove them, get them taken out, and they get to cure a lot of them. So surgery has small role. In adults is a very small role. There's upper airway surgery. I'll show you a picture, has a really small role. It's not a permanent solution, a very extensive surgery. There are other maxillomandibular osteotomy and advancement has small role, very expensive and time-consuming surgery. So these two are pretty much not there. You only have behavior modification, CPAP, and oral appliances. So behavior modification is easier said than done, which we can all lose weight and do everything proper. Easier said than done, and does not always work, but has a potential to work. So this can be tried for mild people or somebody not very symptomatic, and can still be tried along with other therapies. So you only have two therapies really. Oh, okay, this is this side sleeve, so you can put the tennis balls on the patient's back, or there are some belts. People can buy cheap belts that has a either tennis balls or some piece of foam and so on. So that keeps them on their side, can be tried. So, but the only two treatments you have is CPAP and oral appliances. So CPAP, Dr. George showed his uncle's machine, and there's one, there's the mask, and there's a hose, and the machine is also here. So it is intrusive therapy, but it is life-saving. Compliance is low from CPAP, but it is the best therapy out there, especially for severe sleep apnea. The way CPAP works is very, very simple. So it is like a vacuum inside out. So what happens when you put the CPAP mask, the air is coming out of the machine, the air is under positive pressure and will keep your airway open. So this is the closed airway. With the CPAP machine, the airway will be open because of the positive pressure. Very, very simple principle. There are various different masks and some different choices, but this is the basic principle. It does work. It's the best treatment out there. Only problem is, so you can sleep very well. The only problem is the compliance. About half of people stop using it because it is intrusive. People don't like to put it on. It's not difficult to use. Majority of my patients are using actually CPAP as number one therapy because it is the best, is the gold standard for severe sleep apnea and moderate sleep apnea if they're severely symptomatic or they have comorbidities. But it's a problem. So this guy's trying to hang himself with the CPAP hose, as you can see. So there are problems with this therapy. Surgery, we said, it's a really small role. And here you can see you have to cut out all this tissue, but then other parts of the your pharynx takes over. The problem doesn't go away really. So a person may not be snoring, but still may have sleep apnea. They may obstruct further down towards the velopharynx or the epiglottis. The problem is still remain. So yeah, especially if they haven't lost weight, the UPP is not very, very successful. This procedure is again very complicated. You move the tongue out, forward. Again, very extensive surgery. May be successful, but they have problem. This is a treatment which has more promise, but it is really the full face reconstruction, as you can see. So I think we're going to go to oral appliances, and I think Dr. Jamali I want to leave some question for answers and discussion at the end. And I think I'm going to have Dr. Jamali go to this portion of the talk. And then he will take over. Dr. Jamali. I think your slide starts further down at 64, right? So there were a few more slides, but I'm going to skip those and have you sufficient time.
Dr. Jamali, I think you're on mute. I...
Oh, yeah, right now it's okay.
Yeah.
Can you hear me? Good.
Yes,
Thank
wonderful.
you, Sharma, for a beautiful presentation, and appreciate for the time. So as Dr. Sharma was mentioning, I think as dentists, we have the best position to screen for the sleep apnea. A lot of the patients that come to our practice, we're always looking at their airway, we're looking at their jaw and the type of wear pattern on their teeth. Is all can be indicative of there is going to be some form of a sleep disordered breathing that can manifest also in the mouth. And also if we can send them for the proper diagnosis and testing, it's just gonna help them with their overall health. And also if we can make an oral appliance in the meantime for them, we can also help us to do our part in terms of the dentistry side. So what I have been done in the past few years, and this is very easy, as Dr. Shah was mentioning, we can just include one of these questions in your medical health history form for all new patients or all your old patients that they are going to get their medical history updated every like 3 years or so. Any of these questions can start the pop-up questions that can ask more questions regarding the sleep. Or if you see they say yes to any of these questions, we can also give them the stop bank questionnaire, which is very simple, easy. They can just fill it up in a few minutes. And based on that, we can have a discussion with them. And if they don't have the diagnosis, we can send them for the proper sleep clinic to have the diagnosis. Here, we have to send them to a family physician, then have to get the referral. And sometimes it gets a little bit more time consuming. But as Dr. Sharma was saying, these days with some of the home sleep studies as well, we can even start, asking patients to do that. And those results are going to be checked by the sleep physician and aid the patient to know that, okay, if they have a risk of sleep apnea, at least they can go and get the final diagnosis. So any of these questions regarding the snoring, choking, gasping for air, and a lot of times people who are always have morning headaches or TMD issues, there is a big link between the sleep bruxism and severity of the obstructive sleep apnea. So there is a big correlation and association between them. And we see the more severe the obstructive sleep apnea is, the more severe the sleep bruxism issues and the TMD symptoms are. And a lot of times these people, they don't know these stuff are related to each other. I've even had multiple patients that they have had the diagnosis for sleep apnea, but they never, like to use the CPAP. So they just let it go and it start to become worse and worse. And they come to me because of their TMD issues. And then by the examination, we see that, oh, the problem it was the airway. And it's very common, those patients, they tell you, oh yeah, my dentist gave me a night guard but I couldn't even take it in. I worried, I was choking on it, or I saw in the morning, it was on the side of the bed. I couldn't even sleep one night with it. And that's exactly correct, because if someone has obstructive sleep apnea, I mean, just give them a regular, thick acrylic night guard to protect the teeth from damage. We are actually clogging the airway and the air passageway even more. And not only the patient is not going to be compliant even with those, mouth guard, is going to also make their sleep even worse and maybe introduce some more jaw problems. So it's very important, even in terms of the managing the TMD people, to always screen for the airway issues. And then when you're clear that there is no airway issue, there is no sleep apnea, then recommend what type of mouth guard is best suited for them. And again, there is a big overlap between the people with the OSA and TMD that we can address with the appliance by is a very, very nice, thing to help the patient to just alleviate both the sleep problems and also the TMD problems. Another thing that is also common with some of the OSA patients is the gastrointestinal reflux. Sorry, gastroesophageal reflux. So any type of acid reflux, as you know, can exacerbate the problems that they're going to have with the erosion on the teeth. So as the jaw is starting to move or clench in the specific position during the arousal period, during apnea, hypopnea incidents, when there is extra acid in the back of the throat accumulates and the pH of the saliva goes down. So the added effect of the clenching and grinding in an acidic environment, as we know, can cause a severe erosion. And the type of wear pattern on these teeth are a little bit become more evident if you think about it, that the jaw is trying to move forward and or clench and then like edge to edge bite. So you see that type of erosion, and it's very usually sharp and clear lines on the teeth. And when we if we can move exactly. So this is a very nice review paper, and it was in last year actually, and they did the whole systematic review and to see the relationship between the sleep paroxysm and obstructive sleep apnea, and correlation and association between these two. And they see that the worse, as the severity of the sleep apnea gets worse, the severity of the paroxysm is also get worse. So at least they are going up together. So if we can manage one, we can also help the other one as well. That was a very interesting article. And as we move forward, exactly. So this is also a schematic that talks about how when we have the constricted airway and sleep apnea, it can cause the arousal of the jaw muscles as well, and the clenching that happens, plus the fact that the way that the reflux is happening, there's the suction on the back of the throat, and the acid is getting sucked into the mouth. So the pH of the mouth is going to go down, and the acid is also going to cause some inflammation of the upper airways, plus the fact that the patient is trying to clench and stay in a stable position. You see in this image, the patient has come to the almost like a edge-to-edge bite, but the amount of erosion and the attrition is to the level that you are almost getting to the pulp level. So these patients are very common. We see them a lot. And as you see, the problem going to get worse and worse. So the more grinding and erosion they have, the more the bite is going to get collapsed. So the less, airway space they're going to have. So the more effort they have to put to open the airway. So this is a very classical shape of the type of erosion that we see in people with obstructive sleep apnea. So when you start seeing these type of people, and when you see a patient like that, before thinking about restoration, before thinking about night guard, before thinking about doing anything else, just check their throat, just check their tongue. Just look for those anatomical risk factors that Dr. Sharma was also mentioning, and then suddenly it falls into the category, and then you can start talking to the patient. And a lot of time, patient may say, "Oh, I sleep good." But when you start telling them, "Oh, you sleep refreshed, when you wake up in the morning, you feel like good," and sometimes they say, "No, actually, is normal for them that they never sleep good." So because they always have had those issues. So that's another thing to look forward to. In terms of the anatomical considerations, beside the ones that Dr. Sharma was mentioning, that was a very big list, and comprehensive. These are the things that is becoming a lot more evident as you see it. So the patient can have a retrognathic maxilla or mandible, or they can have a maxillary hypoplasia. We have some example of these. We're gonna check it out. A high palatal vault, that's also very common. If the high palatal vault, that's the signs that the patient cannot put the tongue on the roof of the mouth. So you have a narrow upper maxilla. And also when the palatal vault is high, that means that there is less space for the nose and nasal passageways. Any type of deviated nasal septum or extranasal polyp, sometimes we can see that on a panoramic X-ray as well. So that's very evident if there is a deviation in nasal septum or something, you can see there is no passageway during the nares. So that's also very evident in the general examination. Enlarged scallop tongue, tongue tie, and large tonsil and adenoids. I have some pictures of these ones. We're going to go over them together. So retrognathic maxilla mandible, that's very common. And you can see it on a cephalometric as well. And sometimes before and after some form of orthotherapy or even functional appliance therapy, even for kids, you can see how airway is getting a little bit open. And this is a maxillary hypoplasia. So even the patient looks like a class 3, so the lower jaw is pretty wide and good. But because of the maxillary hypoplasia, and also see the even in the nose, the nasal polyps and the very small and narrow nasal passageway that the patient has, plus the fact that they have a very high palatal vault. So it all makes sense that how these things go hand in hand, narrow arches, high palatal vault, and the maxillary hypoplasia. So make patient more prone to sleep apnea. A lot of times, again, maybe these patients are young and they are not having that much problem with their sleep, or that hasn't affected their life to the level that they seek the treatment and diagnosis. But when you start talking to patient and you start directing them and telling about the risk of this and how important it is for their general health, a lot of time patients, they're going to go and seek the proper diagnosis, and they're really going to thank you. There are several patients that they think it changed their lives. It's really effective treatment. Another thing to look forward to is a tongue tie and scalloping on the tongue. So you see these ridges alongside the tongue. That's a sign that the tongue is a little bit larger for the size of the mouth. So we see the crenulation alongside the tongue, and that's also another indication that the tongue sits lower in the floor of the mouth. So as you know, the proper swallowing during development, especially, we want the tongue to be pushed on the roof of the mouth behind the upper incisor to create a palatal seal for the swallowing reflex. But when the tongue is tight, and sometimes these days we can even diagnose that when the kid is so young, they're like a baby, and when we see they have problem breastfeeding, because if they have a tongue tie, they cannot breastfeed properly from the mothers, and because they cannot create a proper seal around it. So these days, sometimes even if we identify it or talk to the parents, and as early age, maybe we doing a tongue tie release, we can help to develop that narrowness of the upper jaw, because if the tongue pressure is not being pushed on the roof of the mouth, so that's very common to see the high palatal vault and the narrower arches. And as the tongue sits tighter and closer to the floor of the mouth, so at night in the deepest stage of sleep, that we lose the muscle tenacity in the genioglossus, that's more higher prevalence of getting the obstruction of the airway and all the symptoms of the sleep apnea. As
Dr. Jamali, just
yeah,
1 second. I'm just going to stop sharing for a second because someone has annotated on the screen. I'll just stop share and reshare so the annotation will go away.
for sure. Perfect.
Yeah.
Perfect. Yeah.
Thank you.
So another very important thing to check for, and I do that for all my complete exam, even for the recall examinations, that shouldn't be that difficult to do a checkup for the patient. You ask the patient while they are seated to extend their tongue out, and you check for the malampathic classification. As you see here, if you see full arches, all the uvula, everything is just class 1. These patients have less risk of OSA. And if we see partial coverage of the uvula on class 2, where still you see the opening, and most of the time, if you see class 3 or class 4 myelopathy, that's an indication that they have a higher risk of OSA. And a lot of times in these patients, you may even see they have a harder time even to staying for their dental appointment. They have a higher gag reflex, and they have that specific type of erosion pattern and the wear pattern on their teeth. And that's a very nice thing to check, because we're checking for oral cancer. We're checking the back of the throat. We're checking the base of the tongue. So we cannot not unsee it. So it's just a matter of the fact that we can just record it in the complete examination form. And also, while we are there, we can also check for tonsils and adenoids as well. So at the bottom here, we can see that depending on how much the tonsillar pillars are covering the airway opening, we can grade the tonsils from grade 1, 2, 3, 4, and that's the approximation. So if you see is around like 50% coverage of the airway with the tonsils is going to be grade 3, more than that, going to grade 4, and grade 1 and 2 is anything less than 50%. So again, we just don't want to be that accurate, but it's very evident that if you see myelopathy class 3, 4, tonsils grade 3, 4, and with all the crenulations or the ridging alongside the tongue, so suddenly that puts the patient in the higher risk of airway problems. So even if these patients, they haven't had the diagnosis for OSA, I start having the conversation with them, because often they're young and they not see the problems. But even if I want to make a night guard or mouth guard for them, I'm going to be more aware of the fact that we're going to design it in a way that is going to be airway centric. So it's not going to hinder the breathing ability. And I'll also tell them that they check for your quality of sleep. A lot of times the patient can see if their quality of sleep is going down. That can also be a risk factor for them, that they can, trigger them to go and do the proper sleep study and get the proper diagnosis. Another factor that we're going to talk about right now is before making any of these sleep appliances, because as we know, traditionally all the sleep appliances, they're just going to bring the lower jaw forward, and this on itself is going to put some strain on the jaw muscles. But on the other hand, you want the patient to be able to use the sleep appliance most of the night for at least in the next how many few years that they are dealing with it. So it's going to be something that they need daily use. So it's very important to check the current condition of all the TMJ and the muscles of mastication and the neck, and make sure that we know their baseline. And then as we are moving the jaw in a more forward position, and we're just going to put a little bit of a strain on the TMJ and muscles, we are doing that within the range of normal for the patients, and it can be something that they can get adjusted to that. So what we do, we're going to check the TMJ for any clicking, popping, tenderness, palpation. And a lot of times I also ask patients if they had a history of clicking and popping, because sometimes the patient may not experience it right away that day in the chair, but they may tell you that they used to have that. So that's also an important factor to note. We're also going to check all the muscles of mastication, neck muscles. We check for any tightness, any hypertrophy. Sometimes we see unilateral hypertrophy that can cause, indicate maybe there is some also interference, or maybe there have been some crossbite for the patient, that they have developed the imbalance in their hypertrophy on right to left side. And if you see any type of extreme deviation, sometimes the mandible deviates a lot during opening and closing. That's also a factor to consider before making the sleep appliance. And as we always do the occlusal classification and the amount of overjet and overbite is also very important. Another factor is that for these sleep appliances, because they are created as a 3D printed nylon material, and it's very durable, it can last for 5 years, and they don't need that much, require that much repair or addition or anything. They're very, very low maintenance. But on the other hand, we want to make sure the teeth are in their most stable position. So if there is any major treatment, any big crown lengthening, and maybe big jaw surgery, any major implant surgery, crown and veneers gonna happen, it's better to do them before we're gonna make the appliance, or have the discussion with the patient that if they're gonna go through some major dental treatment in future, they may need the new appliance. But if they have multiple, loose teeth, or if they don't have that many stable teeth. So sometimes we have to fabricate a different type of appliance for them, or modify this appliance for them, or ask the technician to create more relief around those teeth so it doesn't compromise them even more. I just have a video here of the general examination that we do for the patients before fabricating of the sleep appliance. If Dr. George can play it, and then I can just talk over it. Can even play a little bit faster. So as you see, we check the panoramic X-ray. We check for any type of extreme bone loss or any major treatment. Like this patient has a retained 7.5 that doesn't have any root left in that. We also check the TMJs to see any signs of extreme erosions or malpositioning of the TMJ. We can also see if there is any deviation in the nasal septum. And after that, we just start the extraoral examination that we always do for all the patients, starting with the palpation of the TMJ. If we can go a little bit faster. Yeah, here, Dr. George, if we can go a little bit further forward. Yeah, so we ask the patient to open as wide as they can and then close very slowly, and we try to listen for any sounds. I always also ask the patient if they heard any sound. We can also sometimes use a stethoscope if we want to be more accurate and listen for any type of crepitus or popping sounds. And another thing is that while you're behind the patient and the patient in this position, and when they open and close their mandible, you can see if there is any deviation on the opening or closing of the mandible as well. After that, we start, if we can go, Dr. Joe, a little bit further forward. So after that, we start asking the patient to clench all their teeth together. And then we start palpating all the muscles of mastication, starting from the masseter and temporalis. We also, this is a part is actually interesting. So a lot of times patient, they don't know how to feel the tenderness because they never check their muscles of the face. So you start like palpating their muscles, say, do you feel any tenderness? Say, it feels a little bit tender because you're pressing on it. Said, oh, okay, so but does it feel tender like normal tender? And they don't know what tenderness in the muscle is. So I used to usually touch their hand and I put the amount of pressure that I'm going to use for palpation of the muscles. And I ask them, is it painful? Like here, so no, they feel the pressure, but no tenderness. It's not like you've been to gym and you touch the muscle, you've been for running, you touch the muscle, it feels sore. Say, no, it's not sore. That's good. So, okay, that's your baseline. So if I'm doing this much pressure on the muscle of your face and you feel different, that's considered tenderness. That's considered soreness. And when you do that, suddenly you see, oh, the patient thinks, oh, so if I touch here and I feel pain, it's not like because I'm touching the muscle of my face and my face is weak and it feels pain. No, because that muscle actually has been tender. It has been sore the whole night. So that's a easy way to check the tenderness scale for the patients. And then another important factor beside the masseter and temporalis to check is also the sternocleidomastoid. Again, that's one of the muscles that even if you see as you protrude your jaw forward, that's also one of the muscles that gets some strain on it. So make sure that you have the baseline on that. A lot of time patients don't notice this stuff until suddenly after they start using the appliance and you tell them to check the muscle. So we have to have a very good baseline record. So later on, if the patient is developing any type of additional strain or problem relating to their muscles or the neck stiffness or anything that is not being resolved few hours after waking up, then we know that we are going above the normal range that the patient can get accustomed to. After the extraoral examination, as we mentioned, we're going to check for the malampathy, the tongue, the occlusion, the amount of overjet is also very important. So if the patient has, for example, this patient we're examining, she had around 5 millimeter overjet. And if we start making the appliance around from the edge to edge position, which most of the patient they're gonna be comfortable in that position to start the titration phase. If we start edge to edge position, we are still bringing the lower jaw 5 millimeter forward. So that on its own can give us, some opening of the airway. So it's a very good starting point. And if you see the patient are very severe, have a severe overjet, more than that, sometimes we can use the other means like the George gauge to accurately calculate how much of the maximum protrusion we can set the patient in. And I'm gonna ask George to send you guys these videos to see how to use the George gauge. Not every patient
Yes.
gonna
We
benefit.
also have FAQs prepared, so we can send them out so they can, they can see how to use the George gauge.
Exactly. Because not all patients gonna need it, but you're gonna see that the patients with severe class 2 or class 3 malocclusions is better to check their maximum protrusion, maximum retrusion. And the gold standard these days to we're gonna put them in the 60% of the maximum protrusion for the starting point. And with all different bands that we have during the titration phase, then we can exactly hone in on the perfect amount of protrusion for patient that they are getting the benefit of improving their sleep, not the snoring, improving their symptoms. And also there is no extra strain or pressure on the jaw muscles and TMJ that is not getting resolved a few hours after they wake up. And so yeah, this is a slide that shows the different types of sleep appliances that has been, in practice. I worked with most of them. At the beginning, we used to make a lot of these ones that they were acrylic, some brand names that they were actually very popular. And that was the only thing that was available for some time. These acrylic devices, as you see, one big issue was that the acrylic should need a minimum thickness of around like 2 millimeter or a little bit more. And because they were going for both upper and lower jaw, that thickness of the acrylic has added a lot more bulk to the patient's mouth. And as you see, all these sleep appliances, no matter if they're acrylic or 3D printed, recently there are other competitors also in the market that they have a 3D printed nylon appliances, but all of them have lacking one factor is that they don't have a dedicated airway space. So all other sleep appliances, as you see, they are just trying to improve the symptoms of the obstructive sleep apnea by pulling the lower jaw forward. But as we mentioned, and as we saw the anatomical features of a lot of patients with OSA, they tend to have very large tonsil, large tongue, big, cheeks, sometimes overdeveloped muscles. And just by pulling the lower jaw forward, we could not get that much improvement in the OSA symptoms as much as we wanted because we had to bring the jaw so much forward. And even then, if the patient could not breathe through the nose properly, or if they're habitual mouth breather, still they couldn't, breathe properly because we were not opening any of the air passage through the mouth. It was just by bringing the jaw forward to keep the air going through the back of the throat, but the still patient had to have a good ability to breathe through their nose. And we see a big correlation between mouth breathing and people who have OSA. Usually they have a higher nasal resistance, and they have a higher difficulty to breathe through their nose, especially when they go in a supine position. There are different reasons have been postulated in the literature. But anyhow, the big difference between the Dreamvent appliance that I really like, and again, it's so evident when you start using them and you can work with both of them, even yourself, and you see that having that dedicated airway space is a game changer. And that's the very, very big factor because no matter how big the size of the tongue and the cheeks and everything else is, it gives almost a second nose passage through the mouth. So it's not going to promote the mouth breathing, but if the patient can only breathe through the mouth because of the blockage in the nasal passageway, then this dedicated airway space can stay patent, is between the upper and lower arch, and this part comes out of the upper lip, so keeps everything away from any soft tissue collapse. In this diagram, it shows very nice that how the Dreamvent can keep the patency of the airway, even if the patient cannot breathe through the nose, can keep that passageway. And here it shows that how is staying between the upper lower teeth. as we move forward, another features of the Dreamvent is the addition of these X valves. So this X valve is a very interesting, addition to the mandibular advancement devices. And again, that's another feature of these appliance that I found it that no other ones they have it because of these X valve. So how it works is that during inhalation, the patient can breathe and all the air would come inside. So this X valve inserts into the front of the appliance. So when the patient's breathing, as the graph shows, all the air gonna go in. But during exhalation, there only can pass through these small holes. So that means that there's going to be extra pressure of the during exhalation. We keep some of that positive pressure of the air inside the airway, so it doesn't allow the airway to collapse. So makes the breathing less effort for patients. So by keeping the patency of the airway, by keeping some of the air inside the airway, it doesn't allow that the airway to completely collapse. So it makes it easier for patient to breathe, and also it's improved the apnea-hypopnea index. So we have multiple research that Dr. Sharma and also have been done and shared here as well, that you see how Xvent is or XValve is pretty good in improving the apnea-hypopnea index, even more than just the Dreamvent itself. So in these results of these appliances show that combination of the Dreamvent with the XValve had the highest, efficacy to bring the apnea-hypopnea index to very, very low levels. And if the patient has a moderate or mild, we can say it's going to get it to the very low level and almost completely cure it. And even for some severe patient, it can reduce their number of the apnea-hypopnea index from severe to maybe mild or moderate. And even if the patient need to use a CPAP, I have had patients that they still needed the CPAP, but they still got the oral appliance. And the reason was that they could use their CPAP on much lower setting. So, and they didn't get that much of the side effect of the using CPAP on very high settings. And that's also an added feature. So here we see we have three different types of the X valve that they create a different amount of the positive expiratory pressure. Usually start with the medium for patients, and then depending on how they're responding, we may go for the higher resistance or the lower resistance. Usually if the patients they are in the moderate range, and then they start medium, a lot of them, they get very, very good result. And some of the severe patients that we had, with the high resistance ones, they are still getting some benefit that sometimes they may not even use their CPAP, even though it's not the cure for that, but it still is improved their sleep so much that they don't need to bother to move their CPAP into the airplane if they're traveling, if they're going camping. So it gives a very better alternative to even for patients that they have to use the CPAP. So at least they can have something that can be comparative to that. And this is also another slide that compares the regular sleep appliances, the mandibular advancement devices, relative to the Dreamvent with the dedicated airway space. One caveat just for these appliances is that the patient should have at least a few teeth. So we don't want a patient who's edentulous. So even if you think like if they're Kennedy class 1 or they don't have any posterior teeth, that would be very, very difficult for those patients to fabricate this appliance. And sometimes you have to maybe work other things for them. For example, the time retaining appliances for fully edentulous patients that can be useful. But also these days, sometimes you can start talking to patients that being edentulous for them is causing a lot more issues for them for the general health, because treating their sleep apnea becomes a lot harder. So I've had patients that they started to look for the route of getting some implant supported prostheses to help with their breathing as well. For the registration of the bite for the sleep appliances is again, we want to put the jaw in a little bit forward position. So for many of the patients, we can use a double-sided bite fork that we have here. And that double-sided bite fork puts the jaw at the edge-to-edge position. And that's a very good starting point for a lot of patients. So if a patient is a class 1 and they have like around like 3-4 millimeter overjet and not much, deviation in the mandible, we can just use the double-sided bite fork for our bite. But I always try to send both maximum intercuspation and the bite in the desired bite position for the lab, so they can see how much is the difference from the maximum intercuspation to the edge-to-edge bite. So it gives them a clue as well. But if the patient again has more severe class 2 or class 3 malocclusion, we can use the George gauge to know the maximum protrusion and retrusion. Exactly. So this is the George gauge, as you see, the way that these notches have been designed. So you put it on the upper teeth and fix it, and also on the lower incisor, and then they ask the patient to bring the lower jaw backwards as much as possible, and then forward as much as possible. So that gives you the full range of the maximum protrusion and retrusion, and then we can stay within 60% of the maximum protrusion for the starting point of the patients with class 2 or class 3 malocclusion. Here we also have a video of the scanning. Is a little bit boring at the beginning. I'm just using my ITER Lumina scanner to scan. There are a few factors to take into account for proper scanning. One is that, again, because these appliances are 3D printed nylon, and we don't have that much ability to modify. They're not like the acrylic appliances that was easier to repair and add to them. We have to make sure that the scan is very accurate. So we want as less saliva as possible. And we want to scan the full arches with at least 3 millimeter of the above the gingival margins. So we need at least 3 millimeter below the gingival margins of all the teeth, so the lab can trim the appliance properly. And also for the bite, with the bite fork, one important factor of this bite fork is that we need at least 5 millimeter of the intraocclusal distance for allowing to place the Dreamvent and the dedicated airway space. So we need that 5 millimeter clearance all around. So that's why when we scan the bite with the bite fork, right now you see it in the image, that's the way that the scan is going to show up with that amount of clearance in the desired bite position. So again, we have the maximum intercuspation bite and also the bite with the 5 millimeter clearance. Even if you are taking the impression, you can use the same bite fork and have that 5 millimeter clearance all around, especially to the back molars. And beside that, if you want to, again, do some adjustment on the appliance, is still possible. Very small adjustments, you can use a heat gun, or you can, sometimes use some of these bears that it shows to create more relief along the things that the patients may feel more pressure if they had lots of aesthetic work done, big crown and bridges, or lots of veneers. Patients are usually more worried about that, so we can create more space and relief along those. But other than that, the appliance really doesn't need that much, repair. And then as long as the patient keeps it nice and clean, I've seen this for last 3-4 years that they don't go bad at all. It's very interesting how they.
Dr. Jamali, I think we're running short of time. I think this should have been a 2-hour webinar, actually, because there are a lot of points to cover and
Exactly.
a lot of information, which I think we can pass on to our dear dentists, because we have prepared FAQs, step by step, as to how to choose to go for a single-sided bite fork or a double-sided bite fork, and how to use a protrusion gauge. The George gauge is not available in India, but yeah, we have other protrusion gauges, 3D printed gauges, which can be used to actually advance the mandible and take the bite. So we will just share these how to titrate and all of that. So basically, this webinar, we want to sensitize our dentists to the big problem of OSA, which we are facing as a community, the entire population. So we will definitely share these and your videos to our participants, and I'm sure they will benefit from knowing how, as dentists, we can intervene and actually, try and create a solution for many problems. See, me being a dentist, I visited an ENT surgeon once and I was advised surgery, but I didn't go about doing it. And I'm sure many people are like me,
Yeah.
normal people, we don't straight away go for surgery and all of that. So I've tried standard advancement devices too, but I always felt that, there was a problem since I have a nasal obstruction. So that's where I felt that this airway channel makes the big difference. When you have a nasal obstruction, you're not able to, with your standard advancement device, I don't generally, breathe through my mouth. So my mouth remained closed all the time and I wasn't getting any air and I wasn't feeling good enough. So I think that's what makes the difference. And I think we'll be sharing the detailed FAQs as how to titrate and all of that. So I'm sure that our dear dentist is sensitized to something. And many people are already practicing this and that's a good thing. But I would like more people, common people to understand that this is a problem.
Yeah.
That, and you got to treat it or else you're going to have bigger problems. I'm very, very, I totally agree with what Dr. Sad said about, dementia and brain fogginess. You don't feel fresh. It's not that you can't work. I was able to work. I was able to do everything, but I wasn't able to do it at my 100%. So I think that's what made me or encouraged me to modify my behavior, which I managed to lose a bit of weight, and using the Dreamvent actually made a big change. And so that's how all of this has come about. So this is just for the knowledge of people who are watching. So that's how this is, come to this, and we're having a webinar and we're trying to understand these problems better. So yeah, so Dr. Sharma has numerous case studies, which he's treated over a lakh of patients. So the research is there, the science is there. It's just that we need to open, our minds to this and be a little more aware when the next time the patient comes. So now, now whenever I see a patient, I always also, check whether there is a possibility that patient has OSA. So I request the participants to just post in their questions if they have, and we'll be sharing the FAQs and these videos to you regarding how to go about taking the bite, how to do. You don't need an intraoral scan all the time. You can also use a regular registration, but you should make sure. Yeah, how to take a scan with the bite raised. Yeah, you can take it with an intraoral scanner. So the scanner will detect the upper and lower, and you will get the bite. Okay, so for that, it's a question from Dr. Nikhil as to how to take a scan with the bite raised.
So yeah, it's the same thing as the regular bite that we take, and the scanner itself, the program gonna remove the bite fork from the scan after it's done. So you put the bite fork in the position and you just try to lift the cheek with the mirror, and you do the scan on that side, do the scan on this side, and then at the end, when the scan have been remodeled, the program itself is gonna omit the bite fork and gives you the bite with the 5mm intraocclusal distance.
Yes. So we have certain other questions as to how do you titrate from Dr. Amrita. Dr. Amrita will be sharing you an FAQ, and it's pretty self-explanatory, and there are some videos on YouTube, and we will share them all to you. So you can, it's not very difficult. So you teach the patient how to titrate the device, and we will share that with you. What is all about saliva in the oral cavity when the Dreamvent is in the mouth?
Yeah, so that's one of the first things that the patient gonna get accustomed to. So it's very important to explain to patients, especially patient that they never had the experience of having oral appliance in general, that they're gonna have excessive saliva production in the first few nights that they're going to use the appliance. And depending on the patients, some patients it's gonna take longer for them to accustom to, and some patients they can get used to that faster. But one of the best things to tell them is that after they brush their teeth, wear the appliance while they're still seated, while they're still walking around the house seated, maybe they're on their phone. So this way, that excessive saliva production slowly goes down because the body knows, oh, there's no more food is coming. And after a few nights, and then the body knows, okay, right now the appliance is going to come. So there's going to be less and less expectation of the saliva coming in. And also the patients learns how to swallow with the appliance. So in the first week or two, I tell them that you're going to have excessive saliva production, but wear the appliance while you're still seated, while you're still standing, or maybe 15 minutes, half an hour before going to bed. Even if you see, oh, there's lots of saliva, remove it, drink some water, wash your mouth again, and then put it back on again. And after a few nights of doing that, I almost had no patient that have a consistent issue with the excessive saliva production, and almost all of them after
You just
maximum
need to
2.
be patient, and it. Some patients have hypersalivations. Some people have the opposite. So different patients react in different ways. So if you have hypersalivation, I think it settles. It settles in 1 to 2 weeks. So we have another question. Will it help in patients having nasal congestion or having DNS?
Yeah, for sure.
Yes.
That's exactly that. Then we see the best results in those patients. Like they see the subjective improvement of their sleep a lot better because they are always clogged. So giving them almost a second nose with the appliance definitely that helps them a lot.
Then we have Dr. Rahul who's asked, this is the appliance only for patients who mouth breathe?
So no, again, the appliance doesn't care if you're breathing through your nose or through your mouth, but because there's a big correlation between the people who have a obstructive sleep apnea with the higher nasal resistance and the nasal chronic nasal congestion, especially in the supine position, so they can see bigger effort, more effective, treatment for them. But it's not only for people who breathe through their mouth, because again, while we are advancing the mandible forward and removing the obstruction from the back of the throat, so even if the patient is breathing through their nose, that obstruction should have been relieved so they can breathe through their nose even. So maybe in those patients, they may not get the full benefit of the having the X valve. And for those patients, I had like maybe 1 or 2 patients that instead of doing that, or if they don't like the protrusion to come out in some women, we can use the mini version for them that doesn't have the lip protrusion part. But again, there are very few people, patients like that, and most patients, even if they breathe through their nose, still they get the better benefit with the appliance, because even people who thinks they breathe through their nose when they are in the supine position, if they have any obstruction of their airway, usually some higher nasal resistance gonna come, or depending on the season or the any concurrent, sinus infections, they may not always be able to breathe as comfortably, all the time through their nose. So having this patent airway, it removes all the guesswork and keeps a consistent, breathing for the patient.
Sure. Then there is another question as to, 1 second. In case of enlarged tongue, how does it help with the tongue position in case of enlarged tongue?
So again, by bringing the mandible forward, you're addressing the, tongue collapse on the back of the throat. So if the patient have a enlarged tongue, again, these appliances are the thinnest oral appliances that we can right now make. The thickness is around like 1 millimeter. So even if they have an enlarged tongue, by moving the mandible forward, we are addressing that. But sometimes if the patient has a severe tongue tie, maybe you can also do a tongue tie release. The evidence for that to, alleviating some symptoms is very different. If they do some myofunctional therapy after the tongue tie release, that can also help. But definitely by advancing the lower jaw forward, that's the better result that you see for those patients with the enlarged tongue.
Okay, so another question from Dr. Krishna, how to use the device if the patient is wearing post-orthodontic retainers?
So they don't need any more retainers because it's going to retain the teeth in the same position. So it can work as both.
Okay, so we have Dr. Sozin Riaz, who's mentioned that, can you put some light on the findings that we should check on lateral ceph and also on hyperglossia was discussed. So any imaging techniques that would be required?
Yeah, so these days we can also take a CBCT scan to evaluate the volume of the airway. we can do that very easily, or you can just refer it to the radiologist for them to do that. And actually, you can check the amount of the volume of the airway before having the appliance and after having the appliance. You can also do that with the lateral ceph. And you do the ceph tracing, you can see the amount of the opening of the airway, and then you keep the jaw in that forward position, and then you take the cephalometric X-ray in that forward position with the intraocclusal opening, and then you can see how much the airway has got open. So, these days you can also see there are some websites that they do that for you for the ceph analysis, that they also have a airway detection part. So even if you cannot trace it yourself, which is pretty easy, but you can also use those applications. But the CBCT is very interesting, and it can create a 3D volume of the airway and exactly shows where the obstruction is. And when you put the jaw at the forward position, you can exactly see that. So that's one of the things that I used to do for some patients that they were very worried about this, and we wanted to make sure that in that final titration phase, we would take another CBCT and compare it to the first one, just to make sure that that obstruction is completely open, and they could see visually the amount of air volume that has been added to their airway.
Sure. So another question from Dr. Amrita: is there a possibility that you will turn the nasal breather to a mouth breather?
I haven't seen any records of that, and I'm not sure if that's going to be possible, because we are not promoting, is not promoting breathing through the mouth, because at the when you are sleeping, so breathing is completely unconscious, and we have a very low, no control over that. So I'm not sure how it can, stop people from breathing through the nose, but it just gives them another passage. If the nose is clogged, there is another pass for air to come in.
Okay, so another question is, what if the patient is wearing removable dentures?
Yeah, so that's the difficult part. It depends on how what's the classification of that. If it's a removable partial denture, that's a tooth bound, like a Kennedy class 3, is that they have like only a few teeth missing. I have had some of patients like that, even like if they are missing one or two teeth and they're wearing a RPD, definitely there's no issue for that. But if it's more than that, if there's a distal, posterior lack of any help of posterior teeth, or distal extension dentures or full dentures, unfortunately, they cannot use these type of appliances. And again, maybe we can have a discussion with patients that maybe that's the time to start looking for a implant-supported prosthesis, because I have had patients that they're fully dentulous, and they had to use their CPAP machine on such a high level that they were getting chronic, mouth ulcers and xerostomia. So definitely, it can help them to consider some implant-supported prosthesis to help with their sleep apnea as well.
Yeah. So, I think the screen sharing is stopped. Okay. So, another general question is, they've asked is, do we need to keep wearing the appliance, or does it cure OSA? No, in my understanding, the patient needs to keep using it. So even if you're going to use a CPAP, you need to keep using it continuously. And, so isn't that right, Dr. Jamali and Dr. Sat? You need to keep using it. So there's no other way. So even if you're using a CPAP, you need to use it all your life. So, right. So we have another question. How does it help? From Dr. Gauri Shankar, can this be used in case of OSA in pregnancy?
Yeah, I don't see any contraindication for pregnant women to wear the appliance. Definitely.
Okay, so there's no contraindication in using this for pregnancy. Dr. Sat, anything that you'd like to add regarding OSA in pregnancy? And oh, sorry. Yeah. You're on mute. You're on mute, Dr. Sat.
I don't know. I cannot. No, thank you so much, Dr. Jamali. You've been fantastic. You shared so much knowledge. I learned so many things from you today. And Dr. George, that was amazing. No, it's been been great talk, and I wish I could have and then attended more of your sessions, Dr. Jamali. So no, not from our perspective. The one slide I missed because I didn't want to, steal time from Dr. Jamali. So for mild to moderate obstructive sleep apnea, you could offer, and we do offer both devices. You can say we have CPAP, we have or dental appliance, oral appliance. Of course, you have to do lifestyle modifications to work on weight and so on. And so patients ask me, oh, which one is more effective? Is CPAP more effective or oral appliance more effective? So my answer to them is that CPAP definitely slightly more effective if you do, direct comparison, because, with CPAP, you can titrate up the pressure and you can treat all apneas. With appliance, you cannot just keep moving the jaw forward. Like there's going to be a limit. However, CPAP has lower compliance rates, so 50–60% compliance. So on balance, appliance actually works out better because even if your treatment is slightly inferior, but you use it all the time, your compliance is 100% or 90%, you'll have better health outcome. And that's been shown in multiple studies. There was a recent large hypertension study published. I think there were over 5,000 people. They did comparison between CPAP and oral appliance. And believe it or not, oral appliance was better than CPAP because people used their oral appliance all the time, whereas they did not use their CPAP. So, and there was another study a few years ago on coronary artery disease risk factor reduction, and appliances were better than CPAP because the compliance is so much better. So for moderate sleep apnea, in my mind, those are very similar, equal, and appliance is better for moderate sleep apnea. For severe, again, we will offer CPAP as #1 therapy. But a lot of patients, either they would not be able to tolerate or they don't want the CPAP. People travel, so on and so forth. Some people have claustrophobia, or some people fail. So I position appliances as #2. So either they do not prefer it, therapy, then some therapy is better than no therapy, or they fail the first-line therapy. So actually, a lot of our patients are using oral appliances for severe sleep apnea, and we are collecting data. So I have about 30 plus patients. We're going to be presenting that data later in the year, early next year at one of the international meetings. So it's working out very well with the Dreamvent, with the X-Vent, and with the air channel. I'm seeing really good results. So backup therapy for severe sleep apnea. Dr. Jamali, you have something to add to that?
No, that was pretty good.
Okay. Dr. Sharma, there's just one more question. Is there any protocol in treatment of OSA in pregnancy?
So in pregnancy, I don't think there's, I completely agree with Dr. Jamali. There's no difference. You can go to Dreamvent appliance versus CPAP. My thinking sometimes is that you want to now put in the cost factor and so on. So because it's probably going to be a short-term problem, because patient is likely to lose weight subsequent to the pregnancy and things will improve. So they need to be treated. So if the cost is favoring CPAP in Canada, that may happen, but versus appliance. So I may factor that into the equation. So which is less expensive because thinking that they may not need it long term, right? So in India, it may be otherwise. If the CPAP is going to be so much more expensive, the better to get with go forward with the appliance, right?
Okay, so thank you so much. There are some other questions for which we will be sharing the FAQs, and I think some of the questions are being repeated. But yeah, so I would like to thank our speakers for today, Dr. Sad Sharma and Dr. Zafer. Jamali, for being here today and, for taking us along this big journey of knowing about OSA and how to handle OSA with oral sleep appliances and with focus on the Dreamvent. So a big thank you. It's morning, Sunday morning, and thank you for your time and for explaining this quite well. I'm sure, the time isn't enough to actually go into details of OSA and appliance therapy, but I think we've pretty much skimmed the surface, and definitely you will learn more and more in the days to come. So I would like to thank our audience, a dear audience, for being here and on a Sunday evening and learning, getting an opportunity to learn, relearn, unlearn, or many things. So it's something new and interesting for many. And for those who already know it, I think it would be a refresher. So thank you. Thank you to one and all. So we will share out the FAQs and you can look at the videos and you'll get a better understanding and you can contact us for more information. So thank you once again and okay. Thank you once again. And a special good evening to our dentists in India and a good day to Dr. Sat and Dr. Jamali and our friends from Canada. So hope you have a wonderful evening and a wonderful day. So thank you.
Okay. Take care. Bye-bye.